Everyone, welcome to researchmd.com. We got a great presentation today. We've been doing some analysis on the research paper. Today we're going to look at the recent cancer article which took the scientific community and the world by storm, right? 100% cure for cancer. That's the way they pretty much, all that in the media is kind of going on. So again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also a director of research, assistant professor of medicine, two large medical schools, okay? So today we're going to look at this paper. It was published in New England Journal of Medicine. The title is PD-1 blockade treatment for mismatch repair of deficient rectal cancer, okay? And it was published in New England Journal of Medicine. Tremendous response all across the world. People are thinking there's like a cure for cancer. So we're going to look at this thing. So when you look at the cancer treatment, I think it's important to find out like the types of treatments available, okay? You got surgery, you got radiation therapy, you got chemotherapy, you got immunotherapy, hormone therapy, targeted therapy, and stem cell therapy. So today is like we just kind of talk only about immunotherapy. That's what they use it, using monoclonal antibodies, okay? So what is like 5 types of cancer immunotherapy treatment? Again, there's like 5 types. One is monoclonal antibodies. Immune system can recognize cancer cell that isn't able to. Previously, you have around 75 drugs now. Then you got immune checkpoint inhibitors, which releases the immune system molecular break and kind of make it like a checkpoint. And then you got cancer vaccine. Then you got adaptive cell transfer using genetic editing, and cytokines, man-made versions of proteins that boost the immune system. So today is going to be about the monoclonal antibodies, right? So talk a little bit about colorectal cancer. Very common, lethal disease. Around 151,000 new cases, okay? And so most of them, like around 106 arise from the colon and remainder come from the rectum. So 3 pathways. It's good to understand like the pathways of the how the pathophysiology of the cancer occurs. There is chromosomal instability pathway and microsatellite instability pathway and serrated pathway. So today we're going to focus on microsatellite instability pathway. So when you look at the microsatellite instability pathway, that's the one in the middle. You got the normal epithelia, and you got adenomatous polyposis coli gene loss, and that failure to MMR genes, and that can cause adenoma, and then you have cancer formation. So just focus on the B, the microsatellite instability pathway. That's what they did the study on. So when you talk about microsatellite instability, this pathway involves the mutation of a DNA mismatch repair genes, okay? You got HMLH1, HMSH2, HPMS1, HPMS2, and HMSH6. Mutation of mismatch repair genes negatively affect the DNA repair. So DNA mismatch repair genes, okay? So monoclonal antibody therapy has been shown to promise have like promising results. Again, we talked about is an immunotherapy, and we can target the tumor cells rather than kind of targeting. When you give the chemotherapy, the problem is it kills the normal cells and the abnormal cells, okay? When you use the monoclonal antibodies, you can kind of pretty much say, target that cell. That's what we call target cell therapy. Okay, now the drug today we're talking about is like dostarlimab, okay? That's what, and they were in the treatment of locally advanced rectal cancer. So what is dostarlimab? Again, it's a it's a monoclonal antibody targeted against the human programmed death results receptor PD-1, and the PD-1 receptors are found on T cells when activator serves to inhibit immune responses, okay? And some cancer can leverage this by overexpressing PD-1 ligand, thereby effectively inhibiting the anti-tumor immune response that would typically attempt to destroy the cancer cells. So it's good to know like how does it work on PD-1 and the PD-L1, okay? So now objective. Now let's come back to the study, this great paper published in New England Journal of Medicine. So it's like a prospective phase 2 trial. We got phase 1, phase 2, phase 3, phase 4. when a drug develops, they have to go through. It's only a phase 2 trial using dostarlimab, anti-PD-1 blockade, and see what is the response in the stage 2 or stage 3 rectal cancer. So the background, locally advanced rectal cancer, tumors invading, extending to the mesorectal fascia. Usually like they manage by multimodal therapy. There's chemotherapy, right? There's radiation, there's surgery also involved. And you can currently neoadjuvant therapy, which include induction chemotherapy with the fluoropyrimidine in combination with the oxaliplatin, followed by chemoradiotherapy. And this approach results in pathological complete response only up to like quarter of patient. Some of the up to 50% of the people can die during this time. So again, this is a study design. Let's look at it again. We need to understand it's a phase 2 study. Usually have a very small number of people. That's why in this study they have only 12 people. So what did they do? They gave dostarlimab to these people. The first dose they used 500 milligram every 3 weeks for 6 months, okay? And then how did they follow up? They did endoscopy, digital examination, and then they did that diffusion-based MRI of the rectum. So we got some nice pictures over here. And then after tumor biopsies were performed after endoscopy. Okay, eligibility criteria, what they use, 18 years or older. Patient has to have a mismatch repair deficient stage 2 or stage 3 cancer, and the mismatch repair status is determined by the use of chromogenic immunohistochemical assay, and the staging is confirmed by that in the MRI, and no previous history of immunotherapy, chemotherapy, or radiation for the rectal tumor, or no active autoimmune disease. Those are the eligibility criteria, my friends. So let's look at the baseline characteristics of the population. Very small number, again, we said is phase 2, right? We got 16 patients. Females are 10, median age is 54, white 11, Asian 3, black 2, Hispanics only 1, and the majority like T3 and T4, nodal status like positive around 15, and the median distance from the tumor from the anal verge is around 5 centimeter. So those are now look at the response. Amazing, amazing response, my friend. Look what the endoscopy results, right? Baseline on the left side, look at 3 months, look at 6 months. Where are you going to see this fantastic results? You have rectal MRI below if you want to take a look at it. You got the PET scan. No question, fantastic results after 6 months, right? So, when they did what did they do? They put this patient stage 3 or stage 4 rectal cancer. They gave dostarlimab, all right? And they kind of watch it they gave 9 doses, and they do radiological and endoscopic evaluation and the MRI. Only if there is a residual disease, then you have to do chemo and all the other treatment and surgery. But in these people, all of them had complete clinical response, so they don't have to do other stuff. Just remember that, okay? So the result, 12 patient completed treatment, 6-month follow-up, 12 patient 100% had a complete clinical response, okay? No evidence of tumor or MRI either. On the PET scan also, patient did not receive, so they didn't have to go to the next step, right? If you look at it right here, we can see there was no residual disease, so they don't have to do chemotherapy and surgery or any of that. So that's very, very important. Conclusion, the elimination of tumor after 6 months of therapy with the PD-1 blockade omitted. So it omitted the use of both chemotherapy and surgery, okay? So they're just still observing this patient. So we can clearly say a mismatch repair deficient in locally advanced rectal cancer, highly sensitive to the single agent PD-1 blockade of this drug, right? So very clearly seen. Now let's look at what are the let's do a critique of this paper and see what are there's a lot of strength, but let's focus on the weakness. What are the weaknesses of the study? Okay, follow-up window is short. What is it, 6 months? Single group study, again, this is a phase 2 study, kind of expected. Only few number of patients, small number of patients. Statistics, I don't know, it's 12 patients. What kind of statistics can come out of it? Not really, but the result is significant, 100%, right? And do not adjust for the covariables. So many things in colorectal cancer, right? Age, sex, race, family history, inflammatory bowel disease, obesity, alcohol consumption. So if I'm doing a study, I have to adjust for all of these variables to make sure it doesn't, confounders, right? You heard about it, it's not affecting the study. So kind of a little bit concerned, but more studies definitely is coming up. FDA hasn't approved it, so only prospective phase 2 study. Now, let's look at this is, when we talk about the next thing is like what we have to do, bringing a drug to the market, right? There's phase 1, phase 2, phase 3, and then you get the approval. So we are only at phase 2. Now, a large number of patients to be like phase 3, and then you have to go through like, phase 4, like FDA approval. Remember that. So what is the major disparity? What do I have problem in this study? Look at this. One on the right side, look at one on the left side. What is the disparity in the study, okay? If you look at African Americans consist of many, like almost like 36%. What does that say? More than 1 in 3 can have cancer, right? So we just have to be very careful about this. So look at the people they use. White people are like 11 white people, black 2 also. So you have to be, the Hispanic only 1. Look at it. White people have only 13.9% percentage have like colon cancer. They should have used African Americans, Hispanic, and Asians more in the study instead of using white people. So I don't know. Whoever designed the study, come on, please. Look at the statistics. Look at the prevalence. Very important. Be careful when you do studies, and this is kind of really very upsetting. Use like predominantly the study. Colon cancer affect colorectal cancer like almost 26%, but you only have 2 black people and 11 white people. So big disparity, okay? So thank you so much for watching. Again, it's a great study, but more studies needed to be done. Please subscribe to our channel. Thank you so much. Bye.